Hello, everybody. I am going to give the introduction. Welcome to this year's 8th Anne Klibanski Visiting Lecture Series. My name is Anne Levy. I'm the Senior Program Manager for the Center for Faculty Development at MGH. In today's session, University of London's Dr. Sasha Howard will be talking about gonadotropin therapy in male infants and adolescents with hypogonadism. What is the evidence and what should be best practice? Now, about the Anne Klibanski Visiting Scholar Award, you can see everything here. I'm not going to read it, but this was created in 2020. We are now on our third round of women who have received this award and are about to name the fourth cohort who have applied. This is an opportunity for our faculty to get a virtual presentation at the national or international level, which allows them to create a broader network and get mentoring and expand their reputation, which is very important for academic advancement. Next slide, please. Here you can see information about the name behind the award, Anne Klibanski, our current president and CEO of Mass General Brigham. Very successful in research and an amazing mentor for many faculty, including our current director of the CFD, Miriam Bradella. Next slide, please. Here are the 36 scholars from our 2021 cohort. And then the next slide is 32 scholars from the next year. And then the next slide, 31 scholars are finishing up this year. Finally, more photos. Next slide. The program is only successful because of the help of these great champions who have helped this year's scholars find their speaking engagements, and also worked with outside faculty to invite outside faculty, such as Dr. Howard, to come to MGH to speak. And on that note, next slide, about our visiting lecture series, this is an opportunity to foster collaborations across national and international institutions. It came about because faculty at the other institutions where we were placing our faculty to give presentations and be visiting professors were so excited about the program that they were eager to participate. And so we decided, why not? Sometimes we bring faculty together. So we have one of our scholars speaking with an outside scholar. That was in fact supposed to happen today and unfortunately could not, but it's not unfortunate because Dr. Howard will do just fine on her own. And here are a few institutions that we've collaborated with through the years. Highlighted here is Queen Mary, University of London, the logo for it, to represent Dr. Howard. And now I will stop talking and invite one of our champions, Dr. Madhu Misra, the Division Chief of Paediatric Endocrinology, to introduce today's speaker. Thank you, Madhu. The mic is yours, so to speak.
Thank you so much, Anne, and it gives me great joy to introduce Dr. Sasha Howard as the speaker for today. Dr. Howard is a Wellcome Trust Clinical Research Career Development Fellow and Senior Lecturer at the Center for Endocrinology, Queen Mary, University of London, and an Honorary Consultant in Pediatric Endocrinology at Barts Health NHS Trust. Dr. Howard's research is focused on optimizing the diagnosis and management of patients with pubertal disorders. Her research investigates the genetic basis of pubertal timing using next-gen sequencing and comparative transcriptomic and epigenetic investigative approaches to identify novel genetic variants underlying precocious, delayed, and disordered puberty. So certainly areas that are very close to the heart of any pediatric endocrinologist worth their salt. So Dr. Howard.
Thank you ever so much. It's a fascinating introduction to this lecture series, and it's a real pleasure to have been invited. I'm sorry not to be able to do this talk together with Takara Stanley, but hopefully, as you said, I can do the talk justice on my own. I'm just going to share my screen. Please let me know if you can see my slides. Okay, slideshow, please start. Can you see those slides okay?
Yes.
Brilliant. So it is a slightly lengthy title. I apologize, but I'm going to speak today about the use of gonadotropin therapy in male patients with who are lacking in gonadotropin, so hypogonadotropic hypogonadism. And I'm very aware that obviously we have a very mixed audience here. There are some for whom they are absolute experts in this field, and others for whom endocrinology is not their bread and butter. So I'm going to start with some, perhaps some slightly basic introduction to the development of the male reproductive system, but it will hopefully set the scene for the discussion that we're going to have about how to best manage these patients who aren't able to produce these hormones naturally themselves. So the axis described is called the hypothalamic pituitary gonadal axis. It's one of the key endocrine axes that we clinicians in endocrinology think about and manage patients with conditions where their axis doesn't work well. So at the top is the hypothalamus. I'll just bring up my laser pointer. And the hypothalamus produces the key hormone at the top of this axis, which is GnRH, gonadotropin releasing hormone. That acts in another part of the brain, the pituitary, to release the gonadotropin hormones, which is really the key part of this talk, which are luteinizing hormone, LH, and follicle stimulating hormone, FSH. And those hormones then travel in the blood to act on the gonads, in the males, the testes, and the female, the ovaries, to produce sex steroids, testosterone, and estradiol, estrogen, which then act on the body system in ways that we'll talk about today. But I want to explain to you about why I'm so passionate about this axis and why I truly believe it's the most interesting body system that one can study. And the first reason for this is because this part of the hypothalamus that produces this hormone GnRH, these are neurons that produce this hormone, and they do not first originate within the brain. They're actually born in the fetus, in the nose, in the nasal placode. That's where we can first detect these neurons. And they migrate backwards during fetal life up towards the olfactory bulbs and then towards the forebrain and into the hypothalamus. And as you can imagine, this is quite a tortuous path for these neurons, and it can be fraught with difficulty. And indeed, one of the reasons for patients not being able to make these hormones, GnRH and gonadotropins, is because for some patients, this neuronal migration in fetal life has not been successful. The other reason why this axis is really the most fascinating you can study within endocrinology is that it actually is active 3 separate periods during the life course. So in utero here, we can see that the axis has a very important role, and that is in the development of both the internal and external genitalia, without which we get either issues of sexual differentiation or incomplete sexual differentiation. And then the axis is relatively quiescent at birth and then has another burst of activity in what we call mini-puberty. So this peaks at around 2 months of life, and we can detect both the gonadotropins, LH and FSH, and also the sex steroids. So male infants at around 2 to 3 months of age, if you take some of their blood, they will have testosterone levels that are comparable to a healthy adult male, which is really quite astonishing. And many pediatricians are not aware of the mini-puberty. And then after about 6 months of life, the axis becomes quiescent and is near dormant for several years. So in childhood, you can't measure gonadotropins or sex steroids in children, up until puberty, when the axis then becomes reinvigorated and is turned on again for the 3rd time in life. And you get all the signs and symptoms you would associate with puberty, and from changing physically and sexually from a child into an adult. And then that obviously continues in a healthy individual on into adulthood. And I'm really talking about males today for a variety of reasons, but mostly because these are the patients whom we understand what's happening when they're lacking gonadotropins, and whom we're able to think about how to help them with replacing gonadotropins. Females are quite different. The ovary develops much more significantly in utero, whereas for males, there's a large amount of testicular development that happens after birth. So in the mini-puberty period that I've just described, that's very important, we know, for development of the testicle. The testes will increase in size, and what we've understood from animal models and other work is that there is a particular type of cells, a particular population of cells in the testicle called the Sertoli cells that undergo a period of proliferation during mini-puberty. So for those infants, those boy infants, they will have to have their hypothalamic pituitary gonadal axis turned on in order to have an increase in these Sertoli cells. And without that, that's very detrimental to their ability to make sperm when they go through puberty and become adults, because those Sertoli cells are very important for supporting the development of the germ cells which go on to make sperm. And therefore, without that, an individual, even if they have the correct hormones at puberty, may still have issues with fertility. So there's a very important period of development after birth, and then the testicles are relatively quiescent throughout childhood until we hit puberty, when of course there's a large increase in the size of the testes, with further increase in the number of Sertoli cells, or at least differentiation of those Sertoli cells, and the testicle develops and gains the ability to make sperm. So as I said, if an individual is unable to make gonadotropins, either because they lack the ability to make GnRH, or for some individuals because they have a defect with their pituitary, in that they cannot make the hormones LH and FSH, classically these individuals will present with either delayed or absent puberty. And in males, they'll have underdeveloped testes, as I've just spoken about. But very importantly, we may also be able to identify, at least in males, these infants very early on in their mini-puberty period. Because if they've not had a healthy development of their HPG axis when they were developing in utero, then as I said, they may have some underdevelopment of their genitalia. So a micropenis, a very small phallus, or undescended testes, the testes that haven't properly descended into the scrotum. So these are really important signs, red flags that we are keen to emphasize for our colleagues working in general pediatrics, in neonatology, and in midwifery, to help us to find these infants early so that we can diagnose them early and best manage them and avoid them presenting either in adolescence or even in some individuals who are not picked up until adulthood and have really missed out on many opportunities to supplement them with the correct hormonal therapy. So as I said, most of these individuals will be picked up with delayed puberty. So that's for females, no signs of pubertal development, so breast development by 13 years of age. And in males by 14, they're lacking the first development of the testes. So they'll have small underdeveloped testes under 4 mils volume. And we know that delayed puberty on its own can have some negative sequelae with impact on cognitive and psychosocial outcomes, and also some impact on height and bone density, if not adequately supplemented. But in those with absent puberty who are unable to make gonadotropins, there are really much more impactful outcomes. So if untreated, these individuals will mostly be infertile with lack of sexual development, and this has really significant impact on their cognitive and psychosocial outcomes, or it can do. And there may be osteoporosis because sex steroids are very important for bone density. So it's important as clinicians to be aware of that and to adequately replace these hormones where possible. So a male that has not been treated will present with lack of facial and body hair, a small penis and testes, low bone density and lack of muscle development. And a female individual will obviously also have lack of secondary sexual characteristics with lack of breast development. They won't have their periods, so they'll have primary amenorrhea, and a uterus that on ultrasound can be seen to be small and with a prepubertal morphology, and again may have impact on their bone density. Okay, so that's the description of the sort of clinical scenario that we as clinicians may be faced with, and the sort of issues that we're trying to think about how best to help our patients with. In an individual with hypogonadotropic hypogonadism, so that is normally because of GnRH deficiency, but as I said, maybe because of a pituitary lack of ability to make LH and FSH. We'll pick up this patient occasionally at delayed puberty and sometimes in mini-puberty. This is a rare condition, so there aren't great studies looking at the incidence, but it's something around 1 in 4,000 to 1 in 15,000 males at birth. There is a condition called Kalman syndrome, which encompasses hypogonadotropic hypogonadism with anosmia or lack of smell. And if you recall, I described the migration of GnRH neurons at birth, and because they go up to the olfactory bulbs, they migrate alongside the olfactory or smell neurons. And if you have an issue with migration of those two different types of neurons, then you'll get this syndrome, which is called Kalman syndrome, with the combination of hypogonadotropic hypogonadism with anosmia. So it's very important in a patient without a sense of smell to ask questions about their puberty as well. And these are developmental conditions often, so they may be associated with other defects. This is described in a recent paper by a very eminent French clinician with great expertise in this condition. So in addition to the underdeveloped genitalia, as I described, so undescended testes, cryptorchidism, and micropenis, there are sometimes also other developmental anomalies that we can look out for. Unilateral renal aplasia, sometimes a cleft palate or lip, abnormalities of the teeth, abnormalities of the skeleton or digits, and synkinesia, which is a really remarkable phenomenon, which is mirror movements, where an individual, if you ask them just to move the fingers of one hand, they're unable to keep the other hand still, and they end up moving both hands, and that's synkinesia. So what can we do to help our patients who are lacking in gonadotropins? Well, if we think about what it is that we're trying to aim for, of course, in a young man who presents, for example, age 14 to 16 with lack of puberty, we're trying to induce puberty, to induce and maintain their secondary sexual development, physically enable them to feel that they are compatible with their peers, to optimize their bone health and prevent osteoporosis, and to, very importantly, optimize their well-being. So in addition to muscle strength, to think about adequate libido and psychological health. And for many, many years, we've been doing this relatively successfully with testosterone in males and estradiol in females. We've got quite a lot of hive mind knowledge about this. There's a lot published about it, and it's really quite successful for achieving these first 3 goals. But what testosterone does not help with at all is the development of the testes that I described that needs to happen in early life and also at puberty. And therefore, testosterone cannot help individuals with hypogonadotropic hypogonadism become fertile. For that, you really need to replace gonadotropins. It's only with the stimulation of the testes by those gonadotropins, LH and FSH, that the testis can develop, those Sertoli cells can proliferate and then differentiate and support spermatogenesis within the germ cell population. And I think it's worth just pausing to note that this is a really special condition. It's one of the few rare diseases where medical therapy can potentially reverse the clinical phenotype. So for individuals who have this gonadotropin therapy, there's restoration of fertility in up to 95%, which is really remarkable. So I think it really deserves our attention. And the other point to note is that this is important for patients. So Andrew Dwyer, who is now one of the faculty within your institution, has published many very important papers in this condition, including on quality of life in men with hypogonadotropic hypogonadism. And we know this from published literature, but also from our own clinical practice. If you speak to young men with this condition, they really do care about the way that their testicles look. They care about their potential for fertility. While goals 1 to 3 are obviously important, they would ideally like a treatment that also included goal 4. So we set out, and when I say we, that's our team, including Emma Alexander, one of my excellent clinical fellows who I show the picture of here, to really delve into the literature to see what we know already about whether we can use gonadotropins to successfully and safely induce puberty in adolescents and young men who have gonadotropin deficiency. So we've done a systematic review following the classical protocol and using the tried and tested methodology of systematic reviews. We've screened nearly 4,000 abstracts and identified over 100 studies that met our inclusion criteria, with nearly 5,000 patients from 24 countries. And actually this was, although mostly done in adults, they were mostly young adults with an average age of less than 25 in nearly half the studies. So this is a population that is comparable to the individuals that we're looking after in our clinics, which of course is important. There was a median duration of treatment of about 17 months, and most studies did examine increase in testicular volume, with majority of studies reporting a significant increase in size post-treatment. There are many other studies, many other outcomes studied, including, of course, penile length and different biochemical parameters, but of course, importantly, spermatogenesis and fertility. So in terms of increase in testicular volume, this was 53 studies that reported on this being a significant increase. That's 98% of studies. So really quite overall very resounding increase in testicular volume across the studies that we looked at. All of the studies reported a significant increase in penile size, and there were nearly over 98% that also reported an increase in serum testosterone. So of course there's the risk of publication bias, but I think that's strongly suggestive that gonadotropins within this population do help for attainment of pubertal outcomes in terms of testicular size, penile size, and serum testosterone. There were other outcomes that we looked at in terms of the effect of this treatment on Sertoli cells, which, as I've described, are very important for future ability to make sperm. One of the markers that's produced by Sertoli cells is inhibin B, and there was a tendency to increase across the studies, but part of the issue is that not all centers will measure this. So many of the studies had lack of data or missing data on inhibin B. So in terms of testicular volume increase, we look to see as which therapies might be having the best outcomes with this. And I should just take a moment to explain why I'm describing about HCG when I haven't mentioned HCG yet in this talk. So I've described that there are two main gonadotropins, FSH and LH. FSH we give as recombinant therapy, but LH we tend to give the very biosimilar human chorionic gonadotropin. And therefore, most studies that we see, rather than giving LH, will give HCG, but it is essentially performing the same function. So historically, a lot of the studies have used HCG alone, and more recently, more studies have combined HCG with FSH. And I think it's relatively clear from these graphs that FSH together with HCG does appear to have better outcomes for testicular volume. And of course, it's only a proxy, but testicular volume is a relatively good proxy for the development of the testes and the potential for spermatogenesis. And we've gone on to corroborate that by doing a meta-analysis, particularly of spermatogenesis outcomes. It wasn't possible to do meta-analyses of the other outcomes, as the data were very heterogeneous. But for spermatogenesis, this was possible. And you can see at the top, for those individuals having HCG therapy, they had around a 40% proportion were able to make sperm at the end of therapy. For HCG plus FSH, that was up to 85%. And for GnRH, slightly lower at 72%. So some centers give GnRH, so the hypothalamic hormone, but it is given using a pump, more like an insulin pump. It's not something that's available in many centers in the UK. It is more expensive to give and slightly more complex. The studies were still relatively heterogeneous for HCG and GnRH, but had better measures of heterogeneity for HCG and FSH. So that's a really fantastic outcome from the meta-analysis of the studies that we found. It's always important to think about adverse effects. These were relatively small proportions across the board for any adverse effect, which is quite reassuring. The main adverse effects that were reported on were acne in the orange color, green, which showed gynecomastia or the development of breast tissue in males, and blue, injection pain or reaction at the injection site. That was higher in the GnRH, as I've just said. That's given much more like an insulin pump system. So it is more complex to administer GnRH, whereas HCG and FSH are both relatively straightforward subcutaneous injections that are also in our center very easy to learn and well tolerated by the patients. So I think, the data is out there that gonadotropins, particularly in combination rather than HCG monotherapy, do appear to have the potential for very good outcomes in young men who are lacking in their own endogenous gonadotropin production in order to improve testicular volume and to enable them to make sperm at the end of therapy. But of course, the numbers that I gave you, even for HCG plus FSH, are not 100%. So we're still having a proportion of individuals who are not able to respond to this therapy. And we also wanted to ask ourselves, why might that be? So there's quite a bit of data from the adult world, such as Nelly Pitzelaut's group in Lausanne, looking to see who are the individuals that perform worse, that respond worse to gonadotropin therapy. And it makes total sense that they're the individuals who've got the most severe hypogonadism, the most severe gonadotropin deficiency. And you can see that by the fact that those are the individuals that never went into puberty spontaneously, that have low inhibin B. So as I said, that's a marker of Sertoli cells. So what that's telling us is that those individuals had a lack of gonadotropins, probably even in utero at the end of gestation, and certainly in the mini-puberty, and also had a history of undescended testes, which again suggests that at the end of pregnancy and in infancy, these young boys were not having adequate stimulation of their testicles by gonadotropins. And the only randomized controlled trial in adolescents has also shown the same story. So this was by Julia Roheim in Germany with a very nice study. And what she showed corroborated that. So those individuals that had cryptorchidism, undescended testes, particularly bilateral, performed worse when they were given gonadotropin therapy in terms of final sperm concentration. And those with the lowest baseline inhibin B, with the smallest population of Sertoli cells in their testes, had the smallest final testicular volume when given gonadotropins. So these are the individuals we need to be concentrating on. How can we best help these young men who have signs of severe gonadotropin deficiency with low inhibin B, with history of cryptorchidism, who have not spontaneously gone into puberty? And then we can think about this concept of pre-treatment. So what's happened, as I've described in mini-puberty, is that this Sertoli cell population have had a period of stimulation with gonadotropins, and it's particularly FSH that acts on Sertoli cells. And the FSH allows this population of Sertoli cells to increase such that there are more cells that can then respond to the combination of either FSH and HCG in exogenous therapy or FSH and LH in the endogenous picture in order to make sperm. So there's been a couple of studies that have considered whether we can try in clinical practice to almost recapitulate a mini-puberty for these young men. So if an adolescent comes and we know, for the reasons I've said, that they've had severe lack of gonadotropins even in infancy, can we, even at the age of 14, 15, up to 20, 25, who knows how old, give them back their mini-puberty? So again, Andrew Dryer's group 10 years ago now, but previous to that in Finland, Taneli Raivio and Leo Dunkel did some work trying to address exactly this question. And these are pictures from Andrew Dryer's study where they randomly assigned a small cohort of men with severe gonadotropin deficiency to either receiving pre-treatment with FSH or not, and then gave them GnRH therapy. And what they saw was in the group that had pre-treatment with FSH, they had good markers of testicular maturation, recapitulating that mini-puberty with increase in inhibin B and histological signs that the testes was responding well. And as I said, in addition to the inhibin B, at the end of GnRH therapy, the ones that had the pre-treatment ended up with larger testicular volume. A higher percentage of the individuals in the pre-treatment were able to produce sperm at the end of therapy, with a trend to higher maximum sperm count. So that was very encouraging. And there's been a study about a year ago which tried to show the same in adolescents. So in adolescents aged 14 to 18, again, they use this priming or pre-treatment with FSH. And you can see the testicular volume increased very nicely. The testosterone levels for these young men went up into the normal range, and the inhibin B levels also increased well. There wasn't a control arm in this study, and as far as I know, in the published paper, at least, spermatogenesis wasn't reported. So there's still some more questions to be answered there. But based on all of this data, the systematic review and the other data that I've shown you, in the UK, our centre, along with other groups across the UK, have come up with a protocol, a best practice protocol for use of gonadotropins to induce puberty in young men with hypogonadotropic hypogonadism. So we, as I've described to you, have thought about these individuals in terms of where they're starting from. So in the individuals who have small testes, less than 6 mils, so less than or equal to 5 mils, in whom we think that they've got severe gonadotropin deficiency, we will give them the pre-treatment with FSH. It's 3 times a week, subcutaneous injections, and we're carefully monitoring their blood levels to ensure that we're targeting the target range for FSH. And then we'll add in HCG to give them the combined FSH and HCG therapy, and again, try to titrate the dose to aim for testosterone levels that are in the sort of pubertal ranges. In those that have testicular volumes of more than 5 mils before they've started therapy, we won't give those pre-treatment with FSH because they've got signs of being less severe. They're very likely to have had an adequate mini-puberty if they've already got 5 mil testes in adolescence. So for those individuals, we will start with HCG monotherapy, but if they are not able to produce sperm by 6 to 12 months of therapy, we would then add in FSH. And this protocol is available on the website for the British Society of Paediatric Endocrinology and Diabetes. And in our centre at the Royal London Hospital, which is within the Barts Health NHS Trust, we've been using gonadotropin therapy for pubertal induction for over 10 years now. And also we work closely with our colleagues at University College London Hospital, and we share the same protocol and try to share also best practice. What I would say is that a question I'm often asked is, can you use this therapy in acquired gonadotropin deficiency? So for example, for young men who've had a reason that they have had damage to the area of brain where gonadotropins are produced. Most common individual that we're asked about are individuals with brain tumours such as craniopharyngiomas. And you know, there is no reason not to use gonadotropins to replace gonadotropin deficiency, whatever the underlying reason is. So in our practice, we will offer this therapy to both congenital and acquired individuals. If an individual has had testosterone treatment in another centre in order to start off their pubertal induction, that's not an exclusion criteria. In the randomized controlled trial I showed you from the German group, they actually demonstrated that there wasn't direct harm done by giving testosterone treatment. We acknowledge that we're very lucky in our centre. We have the opportunity for local semen analysis and sperm banking facilities. We're very lucky in the UK to have the NHS, so none of our patients are presented with bills for this. We don't have to worry about managing costs of medication. And I know that, many other countries are, it's a very different picture. I would say that we have many centres across the UK who don't have ready access to semen analysis and sperm banking facilities, and we are doing our best to support those. I have had some patients who have travelled a very long way, at least in UK terms. That's probably not a long way in US terms, but travelling down from the north and the west to London to have this therapy. And this is just an illustration of one of our patients on this therapy who received pre-treatment with FSH. So this is a young man with severe hypogonadotropic hypogonadism with gonadotropin deficiency. When he came to us, he had around 1 mil testes with undetectable FSH and testosterone. The FSH is shown in the red bars. So he was commenced on FSH treatment for the 2 months of pre-treatment with his serum levels coming up into the target range. And then he was started on HCG in addition to the FSH. You can see his serum testosterone rises with this therapy, and his testicular volume is increasing. And over this treatment period, he had a really excellent increase in testicular volume. His serum testosterone came up into the normal range, and he was able to produce sperm on semen analysis after a year's treatment with a reasonably good sperm count and able to bank these sperm. So what we do in our practice is we take the patient through to this point. It does vary. Sometimes it's quicker, sometimes it's slower, but we usually aim not to go beyond 2 years. But hopefully by that point, we will have been able to bank sperm for this patient. And then we would stop the gonadotropin treatment and put the patient on a long-acting testosterone such as Nebido. And then the young man has just an injection every 12 weeks or so, does not have to be doing injections several times a week, which is much more convenient for them. But they know that they've got sperm banked for the future, and either they can use that within a fertility service, or when they want to try to conceive, they can approach the fertility service in the UK, go back on the gonadotropin therapy, and start to make their own sperm again. And we see it as a kind of belt and braces approach. This is just a snapshot of some of the patients we've had recently on the FSH pre-treatment. So these are all individuals with severe hypopypog, and you can see that their inhibin B is quite variable in response. Some of them come up very well into even healthy levels. They all increase, but some of whom stay below 100 picograms per mil. Testosterone, of course, we titrate it, but we do very well at getting their testosterone doses, their testosterone concentrations in the healthy adult range. And despite the inhibin B not always being as high as we would like in terms of numbers, the success rate for sperm banking has been very good, although I acknowledge that there is a range of concentration and motility. But certainly our sperm banking colleagues tell us that they're good enough to bank, and it's a slightly cheesy adage, but you only need 1 sperm to make a baby. Our patients generally tolerate the treatment very well. They pick it up quite quickly. Our nurse just does 1 or if necessary 2 training sessions with them. They do this therapy at home. And there's only been 2 patients that have wanted to discontinue the therapy. 1 did not like the frequent injections, and 1 had a poor response. And unfortunately, I don't think that compliance was very good there. So to conclude this main section of the talk, I hope I've convinced you that gonadotropin therapy to induce puberty in males with hypogonadotropic hypogonadism is both feasible and well tolerated, and we see improvements in biochemical markers such as inhibin B and testosterone, increases in testicular volume, and the potential for spermatogenesis. We have a UK protocol now, and very importantly, we're setting up an international electronic registry called IHH. The paediatric endocrinologists may be aware of the registry called IDSD, which is differences in sexual differentiation, which also includes ICHH and I-Turner syndrome module. And this will be the 4th module within that series, which will be available free of charge to any clinician. And we are very much hoping that clinicians who are using gonadotropin for their patients will be happy to enter their data, because it's really only by collecting the data prospectively, longitudinally, that we will be able to know what we're doing well and what we need to improve on. So I've just got a small section left to talk about, and really I just want to open up the discussion about the potential, the diagnosis of these patients, and possibly the use of treatment in infancy for these same patients. So I've said a lot of this already, and I've shown you the schematic, but I've spoken really about those individuals with severe gonadotropin deficiency who do not respond as well as we would hope when we give them treatment in puberty. And that's because, as I've said several times, they haven't had stimulation of their testes with gonadotropins, potentially in fetal life, but importantly at mini-puberty. And that's a really critical period for these Sertoli cells. And we're not always great at picking up these babies. They do sometimes get missed, but when we do pick them up, what do we want to try and achieve if we're going to treat them? Well, for many of these individuals, they have a very small phallus and an underdeveloped scrotum, and we obviously want to try to help with that. And again, much like in adolescents, we use testosterone. Some centers will use dihydrotestosterone or DHT, and that's relatively successful for increasing the size of the phallus and developing the scrotum. But in addition, many of these infants, as I've said, have undescended testes and underdeveloped testicles. And in order to try and help with these 2 points, again, it's really only gonadotropins that would fit the bill. So once we've identified an infant with severe hypogonadotropic hypogonadism, how might we best think about treating them? We said this, that treatment in adolescents doesn't always work, and the ones that are poor responders are because they've not had an adequate mini-puberty. And the treatment with testosterone in infancy does not lead to testicular development in the same way that it doesn't do so in puberty. So could we potentially use gonadotropins to try and achieve these outcomes? So again, we've done a literature search, this time not a systematic review, as the data is much more limited, but we've done a full PubMed search with citation searching and done some data synthesis on background treatments used and outcomes. We identified 8 studies published over a 20-year period. So we've been thinking about this within our community for a long time already. 67 male infants diagnosed with this condition, with a little bit of a mix, some with syndromic underlying causes such as charge syndrome and septo-optic dysplasia. And there is a lot of variation in the type of protocols that different studies have used. The majority have used a combination of these 2 hormones, LH and FSH, some via a pump giving continuous therapy, some via a more similar subcutaneous several doses a week regime, such as we use in adolescents, and also quite a variety in length of time that they've treated for. So there's not a lot of consensus about this within our clinical world. In a similar way to what I showed you for adolescent gonadotropin therapy in infants does seem to work pretty well for testicular volume. There is a bit of variation. The green line is shown as to the mean for healthy infants. So all the studies, apart from perhaps this one, did seem to have a positive impact on testicular volume. I will say that this study by Kova just used FSH and testosterone and quite low doses of FSH, such that they didn't really achieve target ranges for the infants. Penile length again improved considerably on gonadotropin therapy in these infants, and again the green line shows you the mean for healthy infants. There was only one study that didn't show an increase in testosterone on gonadotropins, and the rest showed an improvement in all of these biochemical parameters. And of course, we want to know what happens long term. If you treat an infant between, for example, 2 and 5 months of life, what happens several years down the line? There's not a huge amount of data. The one study which has had the biggest number of infants included did go up to 10 years in some individuals and reported that there was very good outcomes for testicular descent into the scrotum, a little bit of regression in testicular volume size after they stopped treatment. And we see that also in the adolescents, but that's not unexpected. There's some decrease in the diameter of the seminiferous tubules when you stop therapy. But there isn't a decrease, we think, in number of cells, which is the important point. And the rest of the studies were a little bit limited in their outcomes long term. Much like in adolescents, generally these were well tolerated. There were minimal adverse effects. Some of the infants that had testicular descent then had reascent and needed to have surgical orthopexy. But what our surgical colleagues tell us is that the surgery itself is much easier once an infant's had this gonadotropin therapy. The testes are bigger, they're easier to locate, they tend to be less tightly adhered to the surrounding tissues, and they're much easier to safely bring down into the scrotum with lower risk of damage. There's a little bit of body hair and pigmentation, but we see that also with testosterone therapy. So we've made some initial recommendations, but acknowledge that a lot more work needs to be done here. I think the first and possibly most important point is that we as paediatricians and our allied colleagues need to be thinking about these patients. Yes, it is a rare condition, but as I've said, it's one that if we pick it up, we can really make a huge impact on this individual's outcomes, both in terms of health and psychological well-being. So an infant with quick autism or micropenis should ideally be at least discussed with paediatric endocrinology so a workup can be done. And the endocrinologists themselves may consider an initial treatment course of 3 to 4 months in order to achieve these outcomes that I've already spoken about. Whatever we do, we need to monitor it carefully and to collect the data. And again, we can use the electronic registry, the IHH registry, to collect that data prospectively. We don't as yet know exactly what the right regime is, and we definitely don't know yet whether we should be using continuous LH and FSH via pump or injections. And, what we really need is a randomized controlled trial in these infants. But I think probably that's something that we need to work towards in the future, and it would be great to have a consensus protocol and to collect the data going forward. So to conclude, this is a potential area that I think we should concentrate on. There is some evidence that we can use gonadotropins in mini-puberty to increase testes volume, to facilitate testicular descent, certainly to increase penile length and to improve biochemical parameters. But we need longer term studies to know whether this will really impact on fertility for these young men in adulthood. So I hope in just over 41 minutes, I've covered the learning objectives with some basic understanding to discuss the role of gonadotropins in adolescents and the potential in infants as well. I work with many fantastic people, both on my academic centre at Queen Mary University of London, but also clinically within the Department of Paediatric Endocrinology at Barts Health, and many UK national collaborators and also European collaborators to acknowledge, and very happy to discuss this further if anyone has any thoughts or questions. Thanks for your attention.
Thank you so much, Dr. Howard. That was a fantastic overview of gonadotropin therapy for puberty induction and also in the mini-puberty of infancy. And I think you are, so much ahead of us in the United States in terms of using this strategy. And although we've started to discuss this quite a bit, and so hopefully we'll start to implement this soon. There is a question in the chat from Erica Frank, who asks if there's any value to using gonadotropin therapy in older adolescents who have been on treatment only with testosterone to date.
Yeah, I think there is. In a way, I think we should be led by our patients. In many ways, I think we should be led by our patients. And we've had individuals who have come to us having totally completed puberty in terms of they're on, for example, 250 milligrams every 4 weeks of testosterone esters. They're G4 in terms of all the other parameters apart from their testicular volume. But they would still like to have completed testicular development and to be able to make sperm and bank sperm. And as I said, the lovely study by Julia Roholm's group suggested that there isn't harm to give testosterone. So it's not that, or as far as we know, we're not doing damage. And there are individuals for whom that is enough. I'm not suggesting that every young man with hypogonadotropic hypogonadism should be, strongly convinced to have gonadotropins. But what we know is that there are many individuals who really want this, for whom it's really important, physically, psychologically, for them going forward. And I think that as endocrinologists, we try and replace in the most physiological way that we can. And therefore, I think the question I often get is, why would you give it now rather than wait till they're 25, 30, and just let the fertility services do it? And I think, that's the answer to that, because the patients want it and because it's most physiological. But I totally acknowledge that what we really need is to collect the data and look at, as much as we can, look at that comparison. Are these individuals better to get gonadotropins at adolescence, or can we just wait until they meet their partner later on in life, both in terms of their ability to make sperm, but also in terms of all the other really important quality of life outcomes?
Thank you. I have a question for you. So how old are the young men when you start to get their semen for analysis?
It really varies. So it's the median treatment is about 17 months. So it depends what their starting level is. So we have some young men who are much more of a partial phenotype, and they may come to us and only need, maybe 9 months of therapy before they have testicular volumes over 12 mils and they're able to bank sperm, and then they can stop. It's quite different from another young man who's come with smaller than 0.5 mil testes, who will need pre-treatment with FSH and might need more like the 2-year period before they will be able to give a semen sample and see if they can bank sperm. We say that we wouldn't start this therapy below 12 years because that's kind of the mean age that a healthy male might enter puberty. I have to say I don't push to start at 12. I think we start thinking about it at 12, but it's more like the 13, 14, 15-year-olds that we're really thinking about them making their own decisions about this therapy.
Thank you. And Kamal Tobaloglu has a question for you and also a comment. He says it's great to see you. And he's asking whether it would work as well if FSH is given twice a week, given that compliance could be a potential issue.
Potentially, yes. I mean, like many of these things, who came up with FSH 3 times a week? Why isn't it 4 times a week? A lot of paediatric endocrinology or even endocrinology is not like, people have done many randomized controls and looking at different things. So I think we need to get the FSH into the target range. The nice thing about our FSH pens is that they're like a growth hormone pen. So it's a click, it's a pre-filled pen. So I would argue that, this guy's got the pen in the fridge at home, and we just say Monday, Wednesday, Friday. And then if you tell them 3 times a week, if they forget once, at least they're only forgetting a third of their dose. Likewise, sometimes we need to give HCG twice a week. Yeah, I don't think so, two times a week is a disaster, but I do think there's an argument for trying to find a best practice and sticking with it, collecting the data and see what the outcomes are.
Thank you. Kamal, did you have any other questions? You're muted, I think. No, we can't hear you. If you want to put the point in the chat, maybe.
Oh, can you hear me now?
Yeah, now we can, yeah.
Okay. Hi, great to see you, Sasha. Hi.
Nice to see you.
So in clinical practice, when a pediatrician or pediatric endocrinologist see a patient with delayed puberty, obviously the diagnosis of IHH is not certain and it requires follow-ups and everything. In the meantime, a lot of people tend to give testosterone shots in order to kind of jumpstart pubertal development if this is a constitutional delay. So given that, the question is, would you recommend that we should hold on to that testosterone shots and wait for gonadotropin treatment?
No, I don't think so. I mean, I totally get your point, and that's kind of, a whole nother talk about how to diagnose. And I think we need to not be too worried about damaging anything with testosterone. I think there are patients who are older and clearly haven't gone into puberty by, certainly by 18, but even 16, 17 with undetectable inhibin B, it's clear. There's a whole nother group of patients for whom the diagnosis is much less clear. And I agree that, I wouldn't reach for gonadotropins straight away. An argument is that you won't do any harm with gonadotropins because that's only what they would be endogenously producing, but it's a complex therapy. And, I think we don't do any harm with that 3 or 6 month course of testosterone to make the diagnosis. And I certainly do that in my clinical practice. If I think that this patient may have constitutional self-limited delayed puberty, if they don't have a clear genetic or clinical diagnosis of hypoc, then I also do that. Stop, see if they respond. If they respond and the testicles are increasing, I'll hold off. But if for whichever way down the flow diagram we've convinced ourselves that this is a diagnosis of hypogonadotropic hypogonadism, then I think that we should be at least thinking about discussing with the patient, offering them the potential for gonadotropin.
So Sasha, this is fantastic. I have to move on to another meeting, but I think there's another question in the chat, and Anne Levy is going to help you with that one.
Yeah, there are a couple other questions. We're already at 1, but if you have the opportunity to answer these 2 questions quickly, that would be great. We have one from Joel Franklin. Is it mandatory that testicular volume reaches 12 milliliters before doing semen analysis?
10 to 12. I mean, I think we have conversations also in the Klinefelter community that it's quite a stressful procedure for a young man. It's very disappointing if they don't produce adequate sperm. It can be quite disheartening. So, maybe again, we're lucky in the NHS. I don't have to think about, the cost of an extra 3 months of treatment. But I think it's a good, threshold to get to 10 to 12 before you look, because the likelihood is going to increase. No, you could do it slightly smaller, but the data suggests that that's when the mean volume that individual is going to be starting to produce reasonable numbers of sperm that could be collected and counted.
Okay, thank you. And one last question from Neil Smith. Do you get patients who express a preference to natural testosterone delivery over injected gel forms? As a patient, I feel better, he says, with HCG treatment.
Yeah, I mean, I do. it's a balance, and I think again, you know, in an ideal world, you would, you know, be able to offer that a patient could just continue with, for example, HCG treatment alone. It is also a balance, even in the NHS, with financing. So within our trust, it's we have an agreement, and it's on the formulary to use it for an indication for pubertal induction. We are not funded to use it for ongoing hypogonadism, you know, later on in life. I think it's an under-researched area that would be good to look at more as to, you know, patient experience. But I think it's slightly to do with practical cost considerations as well.
Great. Well, thank you so much, Dr. Howard. This was amazing. We've gone over time because of the great interest in what you have presented. It has been an honor to have you here at MGH, if only virtually. And thank you all for coming. Have a wonderful afternoon. And for you, Dr. Howard, a wonderful evening. Goodbye, everybody.
Thank you so much for having me. It's been a pleasure.
Thank you so much.